Hello, hello, and welcome to today's episode of Talking All Things Cardiopulm. I am your host, Dr. Rachel Barisi. Today's episode is sponsored by Jane, a clinic management software and EMR that helps you handle your clinic's daily administrative tasks so you can free up your evenings and weekends. The Jane team understands how precious your time is and recognizes that charting can often be the most time-consuming administrative task for practitioners. That's why they're here to help. To save you from having to start your chart notes from scratch, you can check out Jane's template library, which gives you access to templates that have been generously created and shared by health and wellness practitioners in the community. Once you have a template you like, you can choose to customize it further with charting tools such as range scales, text fields, checkboxes, and much more. To see how Jane can help you spend more time doing what you love, head to the show notes, click on that link to book a personalized demo. Or if you're ready to get started, you can use the code CardioPulm1MO at the time of sign up for a 1-month grace period applied to your new account. Thanks again, Jane. All right, welcome back. Happy new week. Today I wanted to talk a little bit about hypo and hyperkalemia. I want to talk a little bit about the physiology, not get too deep in the weeds, and then maybe bring out 2 quick cases to help it stick and kind of bring that picture to the forefront. So just like right off the bat, hypo and hyperkalemia, low and or high potassium, both have risks that we need to be aware of as PTs, especially PTs treating in the hospital setting. Part of your chart review should be assessing lab values, and based on the clinical presentation, the trends of said potassium or any other lab value, and just the overall picture helps you make decisions about whether maybe you might hold a session, treat with caution, what vital signs you're monitoring specifically, and maybe the level of activity tolerance that the patient will be able to tolerate. It's important for you to play a role in this. It's important for you to have a voice. It's important for you to have resources available to help either stand your case in either holding or progressing, whatever it might be. And I think that we should be part of the conversation and not necessarily be asking for permission to see patients, right? This is our license and we have the education to make decisions. Yes, we should be having conversations with our team. And sometimes maybe with team discussion, we might do something different than what we would have originally done. But your voice, your opinion, your skill, your knowledge base matters. So first and foremost, if you do not have access to the acute care lab values manual, it was recently updated in 2023. I highly recommend that you get your hands on that. That's through the acute care chapter. They did one in 2017, and I'm almost certain it was 2023 that the most recent update came out. You will hear me say this a lot. As years have progressed throughout my career, things have changed quite a bit. There was a time when we were treating that if a person had a hemoglobin less than 8, that was a hard hold, right? That is no longer the case. And I would agree that it shouldn't be, right? And so I have many different reasons why, but understanding the person is kind of where those decisions start to really matter. As we progress in medicine throughout the years, healthcare, mobility, things are changing. Things are getting more, maybe lenient is a good word, and there's much less holds. I have a podcast on contraindications. There's 2 parts to that. I highly recommend that you take a listen to it because I go into some detail about that there. And there's pros and cons to all of these decisions, right? When you have more leniency, you will be able to mobilize patients more quickly. But with more leniency, we have to understand the impact or the possible consequences of progressing someone with maybe low hemoglobin, low potassium, high potassium, whatever it might be. We have to understand the implications. We have to be on the lookout for them. We should absolutely be monitoring and we should be adjusting. That's kind of my big token piece here. We should be paying attention. to lab values. We should be watching trends because trends matter more than anything, right? If something has acutely changed versus something has been chronic for weeks, those are two different pictures for pretty much any lab value, right? So it's important for us to have that piece when we're chart reviewing. The problem with not having these hard holds is sometimes we have less weight to stand on when we don't feel comfortable progressing. Sometimes it's nice to say, hey, we don't treat if fill in the blank. But as years and years progress, there's much less hard holds. And so it really does become more of a conversation. And I think this is great if we are part of the conversation. Okay. So I had a question asked of me. This was actually a couple of months back. Somebody was preparing for the NPTE and they sent me a picture that was in a book, a reference of some sort. And it basically alluded that I believe it said hypokalemia was a risk for ventricular arrhythmias, but it did not state that hyperkalemia was. So they were really confused because I have always made it a point that both can cause it. So here's the thing, there's going to be differences in different references, especially in books used to help study for the MPT, where it's more like bullet point. You might not be able to get all of the information into one section, but I want to be very clear about this. Both hypo and hyperkalemia can cause ventricular arrhythmias, period. This is why it's important to be assessing potassium in your chart review. Potassium plays a huge role in cells across the body. So, especially with muscle contraction, both skeletal and cardiac muscle play a huge role, or potassium plays a huge role in both skeletal contraction as well as cardiac contraction. And it plays a very important role in maintaining the resting membrane potential in cells. So essentially, the inside of a skeletal muscle cell is negative, and that's filled with cations and potassium. And then the outside of the cell is positive. And when a contraction occurs, we have sodium influx and potassium efflux. So sodium rushes in and potassium rushes out. And so we have this depolarization, repolarization situation happening. Same is true in the heart. The only difference is that in the heart, we have sodium and calcium influx to create depolarization. And then same thing, potassium efflux creates repolarization. So the two big symptoms or presentations that you will see with either hypo or hyperkalemia is actually muscle weakness, paralysis in its most severe state, and ventricular arrhythmias, because they affect very significantly the skeletal muscle as well as the cardiac muscle. And so we cannot ignore that like major piece of information. So in cells in general, we have a high amount of potassium inside of cells, and so intracellular, we have very high potassium, and extracellular, we have very low potassium. It's something like 4. So when we have adjustments outside of that, you're going to have repercussions. And so normal potassium levels is somewhere between 3.5 and 5. There are some differences depending on your reference, but that's usually the standard reference, 3.5 to 5. That is your extracellular potassium. So I just said, based on textbooks, you only have about 4, right? That's smack dab in the middle of that range. So when you start messing around, going up and down outside of that range, you're going to have changes and you're going to have potential concern. So I was always taught that Potassium less than 3, it used to be a hold. And again, it depends on where you work, right? So some places will kind of implement some holds and you just have to be consistent across the board. And some is more of a conversation. And I think just across the board, we're leading more into conversations. And I just want to kind of blanket statement that. But less than 3, we're going to say is like more than a yellow flag. And greater than 6 was always where we held. In the updated critical lab manual, in the updated acute care lab manual, critical hypokalemia is listed as less than 2.5, and critical hyperkalemia is greater than 6. Okay, so outside of those ranges. Now, both hypo and hyperkalemia break it down into whether this is like something mild versus moderate, severe. Hypokalemia is listed as mild between 3 and 3.4. So that's just under that range, no big deal. You're considered moderate between 3 and 2.5. So that's where I really say we have that yellow flag. And then less than 2.5 is considered severe. Let's throw a hot red flag on that one. So some symptoms that you might see with hypokalemia include muscle weakness, muscle fatigue, or just overall general fatigue, cramping, potential palpitations, and also some GI symptoms like constipation. In very severe situations, so that would allude to less than 2.5, you can have fatal arrhythmias, including VTAC, VFib, and or cardiac arrest, as well as respiratory muscle paralysis, right? Because the diaphragm is skeletal muscle. So we can't forget that that's, not included in here. Whenever you are seeing a patient with hypo or hyperkalemia, really what the team is trying to figure out is the underlying cause. And typically, once the underlying cause is rectified, then that risk of arrhythmias and the muscle changes should dissipate or be removed. So when you're thinking about hypokalemia, and this is more for the person who is maybe sitting for the amputee or even for their CCS, we're really thinking about reasons that there's a loss of potassium. So a lot of the possible causes: vomiting, diarrhea, heavy sweating, any kind of alkalosis, so like metabolic alkalosis. And a very common one is the use of diuretics. So loop diuretics are not potassium sparing. So they're going to eliminate more potassium. And we lose the primary way that we lose potassium anyway is via our urine. So it's a high role in kidney function here as well. On diuretics, specifically loop diuretics, you have a lot of excretion of potassium. So patients who are placed on a loop diuretic are typically given a potassium supplement. So it's very important for that patient to be taking that medication simultaneously so that they don't end up in a hypokalemic state. Before I get into like EKG changes, because that's where I was just about to jump to, I wanted to throw one piece in here because this is the case I wanted to throw in really quick. Nutrition is a huge piece of hypokalemia or possibility cause. So eating disorders are on that list, as well as like specific dietary restrictions. If you're not getting enough PO intake, it can really lead to some concerns with hypokalemia. From an EKG perspective, the way that I help or like to teach this so that it's easy to remember is that hypokalemia has a depressed T wave. So hypo means less, smaller T wave. So that's a big finding that you're going to see on EKG, as well as ST depression, as well as potential prolonged QT interval. And this actually could potentially cause presence of a U wave, which can sometimes be hard to see because it can get buried in the T wave area. And they might have peaked P waves, but the big quintessential change that you typically see on EKG with hypokalemia is depressed T waves or depressed ST segment. So, thinking about that picture, if you are having changes on ECG and you are hypokalemic, that risk for ventricular tachycardia, VFib, cardiac arrest, maybe you're having a higher frequency of PVC should be taken very seriously. Because as we have this hypokalemic state, we have less potassium. And we said that repolarization occurs due to an efflux of potassium. So we have less potassium. We have this difficult time now with repolarization, which actually allows for, you know, relaxation of the cardiac muscle. If we have a prolonged QT interval, we're going to increase our risk for flipping into a ventricular arrhythmia because that right around that repolarization area is very sensitive. So if we have this prolonged QT interval, if we're having changes in our T wave, we could potentially flip into VTAC, VFib. So I think, you know, as clinicians, we, especially if you're in the hospital setting, especially if you're in like a trauma one facility, if you have patients who are very medically complex, we see these very extreme cases. We see maybe extreme lab values. We might be, you know, front runners in early mobilization and things like that. And so I do want to just sometimes bring back the precaution because these things can happen from just a change in a lab value. So I had a case recently, and it was just a very interesting case. And I might do a spin-off of this about this case. I had a 42-year-old female who went into VFib arrest due to hypokalemia. Her K was less than 2 when she arrived at an outside hospital, and she received CPR and 27 rounds of shocks and was brought back. And so the first question is, you know, what was the underlying cause? She's young, you know, we went into VFib arrest. I believe she actually went into VFib arrest outside of the hospital and was taken care of by EMS and brought into the hospital. So those 27 rounds, I think, was from outside the hospital to inside the hospital. So that's just a huge piece anyway, because we know risk or survival percentage is so low if it occurs outside of a hospital setting. So big picture on this one is that she had a gastric sleeve placed 1 month, I believe, to the day of her VFib arrest. And so that's just a huge picture. With surgeries like gastric sleeve, there's a very specific nutritional program that occurs post-op. It's pretty much near liquid for a month. They have very specific things that they can and cannot eat, even once they're back on solid food. So the malnutrition perspective on that patient population is tremendous. And then the long-term ramifications still exist. So I think that alone can be its own separate topic because it can place such a it may have such negative impact on long-term health post that type of surgery. And I think that is something that should be discussed because it is high risk long-term. So big picture, she had the gastric sleeve. She ends up with hypokalemia. She has VFib arrest. She is brought back 27 rounds of shocks. She had a Impella placed because her EF was down to 20%. She VFib arrested again, was brought back again, was placed on ECMO, intubated. then had an embolus in her left lower extremity. It was removed. She had an endarterectomy. She had an embolectomy, placed on TPN, and is now in that recovery period. So she had a complicated course. When I saw her, I think she was already in the hospital for about a month time, significant deconditioning, profound orthostatic hypotension. We went from 120 over 68 to 85 over 50, with high heart rates as well. And she was throwing PVCs. So knowing her history, making sure that you're checking her lab values, that her K is in a normal range, that you're monitoring ECG throughout, that you're monitoring vital sign response, because there are so many different pictures here that we can now think about, like as the monitor from a monitoring perspective, right? Like think about the bed rest changes that have occurred over a month's time. Think about the continued malnutrition due to the gastric sleeve that still exists. We've had the VFib arrest due to the hypokalemia. So big picture, you are monitoring and you're paying attention to that ECG, and those PVCs are very important, right? So this would be someone who you would want to know if they have that increased QT interval time. What do their T waves look like? Are there changes during your session? These are all super important things to pay attention to because she is technically still at risk, right? So, and she did not have an ICD placed because in theory, the cause is now known. If they can maintain said hypokalemia or maintain her potassium levels, then we should mitigate that risk. But the nutrition was still a big piece of this. Actually, while we were in our session, they were talking about what she could potentially eat. And there was just, she has this list for her gastric sleeve. She had this list for cardiac diet. And I think she had a third diet. It was kidneys, because her kidneys were also failing post this whole event and was now on dialysis. So really big picture stuff there. But the hypokalemia isn't something that you're just going to ignore because that risk exists. And so sometimes I think having those cases help bring that to the forefront. And also just in general, that if you are seeing patients post-bariatric surgery, either acutely or, further out, that you are assessing lab values, because I have seen so much malnutrition in that patient population. And so lab values can be out of whack for a long period of time. And so they correct that, right? They can correct that by giving replacement potassium, and they could do it from an oral perspective if it's not so severe, or in these acute situations might give IV potassium. And so paying attention to those lab values would be very important in that specific patient, right? That she's not trending under that less than 3 mark. And I think she actually had a goal of greater than 3 on her potassium as like a standing goal for her. On the other side of the coin is hyperkalemia. So we have increased potassium. And so symptoms-wise, very similar: weakness, paralysis in severe situations, and arrhythmias. And they actually put the risk of arrhythmia starting at greater than 5. So hyperkalemia, same thing. You are paying attention to those lab values. You're having discussions with your team, and you are monitoring said ECG. With hyperkalemia, you're actually going to see high T waves. So hyper, increased T waves. So you have these peak T waves, and that can occur somewhere between a K of 5.5 and 6.5. You can also end up with loss of P waves, which is said to occur somewhere at the 6.5 to 7.5 marker. And then you might get a widened QRS at the 7 to 8, and per one research article stated 8 to 10 is where the cardiac arrhythmias are likely. From other resources, they are saying greater than 5, you're at risk for arrhythmias. So do not pass go. You're paying attention to lab values. Potassium is a big one that you should be checking, even just as a glance over in the acute care setting. But if you're outside those ranges, you're paying attention and monitoring vital signs. From a causes perspective, rhabdo is actually high on the list. Endocrine and renal problems are probably the primary causes. And then there can also be medication. So we talked about the person who's on a diuretic, a loop diuretic, they get potassium replacement. Maybe they're taking too much of the potassium replacement for whatever reason, and that starts building up in the system as well. Diabetic ketoacidosis is high on the list. Some issues with insulin deficiency. And from the hyperkalemia perspective, we have an acidosis, a metabolic acidosis issue. And that can actually cause shifting of that intracellular potassium to move extracellularly, and that's how that number starts to linger. I would say that if you have patients who have end-stage renal disease, who are on dialysis, peritoneal or hemodialysis, that you're paying attention to potassium as well, because it is possible that those kidneys are not able to excrete said potassium. And again, it starts increasing in the extracellular fluid, which you would then see on your lab value. So, super important that you are paying attention to lab values when you're treating. Super important that you're understanding the implications of treating when you are outside of those norms. And if you're in that area where you're not, it's new, it's acute, there's a change, there is no harm in having a conversation with the team. Is there a plan in place? For the hypokalemia person, they might be receiving potassium replacement via IV. There is no harm in waiting until that potassium replacement is complete, and likely they're reassessing blood values, right? So then you would potentially wait and see and then treat. On the other side of it, especially in the end-stage renal population, a lot of times the potassium might be very high, and that might be chronic. And if it's a chronic issue and they sit maybe high 5s or 6s, it's less of a concern. The acute change seems to be more problematic than this like chronic change. But if they're due for dialysis that day, that will be taken care of or potentially improve after said dialysis. So kind of having, conversations, understanding implications, understanding the concern, right? Like, what is the concern? The concern is that we start to exercise and they start increasing maybe PVC production, or they flip into a fatal arrhythmia. That's the concern. Where does that risk start? Are they being treated for it? Is it already being replaced or decreased? If something is, chronic, maybe you're not as concerned. Whatever the specific case is, that's going to help you make decisions. But I would caution you, and this is a personal thing about your scope of practice, your license, that you're not just asking for permission, maybe from the nursing staff, to see that patient. This is not the piece of it, right? You can absolutely and should have discussions with the nurse, but it's not a ask for permission, so to speak. And I think that's an important piece here, that you are working in your scope of practice, that you are, you have your own license, that you are making decisions as well, and that you're part of the conversation. And if there is concern, that you articulate the concern. Maybe even discuss what their rhythm has looked like from this point forward. What is their QT interval? Are they throwing more PVCs? Have they had episodes or runs of non-sustained VTAC? That's part of the conversation, right? What does their blood pressure look like? All of those pieces play a really big role in your presence there as well. And so I kind of wanted to put that out there. From a case perspective, I recently had a patient who just received kidney transplant. So she was 32-year-old. I'm sorry, it was a 32-year-old male, status post kidney transplant from end-stage renal disease. He actually had a late surgery the night before. So he's post-op day 1, which we're typically seeing them post-op day 1, typically in the morning, but he was a late surgery. He would have come out of his bed rest precautions, by the time I would go see him, maybe 9, 10 o'clock in the morning. But on chart review, his potassium was 7.4. Now, even though he is end-stage renal disease, even though now he has a replaced kidney, this was acute. This was new. This was a significant change from the days prior. This was a hold. And part of the conversation, he is going to dialysis later that morning. And now with patients post-kidney transplant, they don't always continue dialysis post-transplant. A lot of times they take out their port. A lot of times they wait to see how good their urine production is. Sometimes they wait and see how quickly their EGFR is picking up. But sometimes they still require some assistance via dialysis, especially if they've been on it for a prolonged period of time. So he was going for dialysis. We're going to let that happen. And then when he comes back, they'll likely redraw labs and you can see where he adjusted to. And he actually dropped to 6 later that day, but he came back super late. So next day, we're seeing him for evaluation. So part of the conversation, don't be afraid to ask questions. Don't be afraid to articulate your concerns and see what the plan is, right? If he's going for dialysis, I'm going to let that happen. And then we can reassess after, see what time of day it is, see how he's feeling overall. So hypo, hyperkalemia, both have importance in assessing for chart review. Hypokalemia, we have low potassium, potentially low T waves, potentially ST depression. We have concern, maybe yellow flag less than 3, red flag less than 2.5. Have conversations with your team. What's the standard of care at your hospital setting? But concern is, big picture concern is VTAC, VFib, potential cardiac arrest. Same is true on the hyperkalemic side. Now we have high potassium in the system. We have potentially high or increased peaked T waves. We can also have ST depression. We can also have peaked P waves. We can also have changes in our QRS, widened QRS. And big picture is we can have concern for VTAC, VFib, cardiac arrest. So we have the big player arrhythmias up here. So we want to pay attention to, is it an acute change? Is it a chronic change? What is happening from the medical perspective? How are they adjusting to it? Are they concerned about it? Are they, changing medications? Are we reassessing lab values? And then what's the plan? Be a part of the plan. Be a part of the conversation. All right, so I think that's all I have for you today. I hope that was helpful. Hypo versus hyperkalemia, something that we see very commonly in the hospital setting, something that we should be a little bit well-versed in, something that we should be assessing on chart review. And if we have patients that are outside of those norms, that we're actually paying attention to ECG and definitely monitoring vital signs. All right, I hope that was helpful. If you have any questions, please reach out to me. I hope you all have a wonderful day, and whatever you have to do, get after it.